So this video will talk about the placenta abnormality in labor. So I always get confused when the question give this is a body big and large above the umbilicus uterus and soft. This one, if that's the case, then you're having a atonic uterus, uterine atony. And the first next step with uterine atony would be you try to do a fundal massage. Then you do a oxytocin, I think. And then for another question they usually ask is, okay, the mom just given birth and then the uterus is very firm and it's at the level of the umbilicus or below the level of the umbilicus. If that's the case, then it could be some placenta remnant in the uterus, but they usually give this scenario when they try to take out the placenta and then it started bleeding. So this is a placenta accreta, which is also a common cause of postpartum hemorrhage. Atonic uterus is also a common cause of postpartum hemorrhage. This is the most common cause. This is a common cause. So if you have a placenta accreta, it usually causes prolonged the stage of the delivery, right? And then, so there is a lot of pathology with placenta. So first one is the placenta. In this video, I'm going to talk about placenta abruption, placenta previa, symptoms, risk factor, and management. Then the vasa previa, and then the placenta accreta. So the first thing is the placenta abruption. So for the placenta abruption, you have to know that it happens in the third trimester and it's a painful bleed, right? I usually look at the questions, the symptoms, sudden onset dark vaginal bleeding. Sometimes the patient, the mom, won't present with bleeding, so it's usually a retroperitoneal bleed, so the mom will have shock, right? It's bleeding, but there's no blood coming out from vagina. In that case, since it's a retroperitoneal, she will have back pain. She can also have abdominal tenderness, uterine tenderness, right? And hypertonic rigid uterus. So anytime the placenta pathology, remember placenta accreta, hypertonic rigid uterus too. Placenta abruption, hypertonic rigid uterus too. So this you can find it in placenta accreta too, right? Then you will also see a fetal distress, absent fetal movement, deceleration. The thing with placenta accreta is it's usually seen after birth. This is before birth, right? So if you suspect any of these symptoms, the first thing, do not do any vaginal exam, clinical, and in the question, they try to trick you by giving, okay, the best next step is ultrasound. But ultrasound is likely to be the answer because it has very low sensitivity. And then ultrasound is the right answer for placenta accreta. To confirm, ultrasound is not the right answer for placenta abruption, right? And then they like to ask the most common risk factor: hypertension, preeclampsia, eclampsia, abdominal trauma, previous eruption, smoking, cocaine, PPRM. So these three are from UO. So hypertension is the most common risk factor for placenta abruption. Remember that. Not cocaine, not smoking, or not PPRM. And the treatment regimen is, first you have to look if it's stable or unstable. Is it stable? Normal fetal finding, stable mom? Then you just say, okay, we're gonna observe you, hospitalize you, and we're gonna do a complete bed rest, right? So that means no vaginism, no sexual activity. And then you look at the week, right? So if it's the patient is less than 34 weeks, you have to give steroids, and you try to give tocolysis, nifedipine, not indomethacin, right? Indomethacin will close the BTA, so you'd give nifedipine. Then between 34 to 36 weeks, if it's stable, both the mom and the baby, you try vaginal delivery first, right? If you have contraction. If you don't have contraction, then you wait. If it's unstable, then you do a C-section. If anytime, acute symptom, shock, C-section, right? So the treatment for placenta eruption is unstable, go do C-section. Before C-section, unstable, if it's less than 34 weeks, you might want to give steroids. But if it's stable, then after 34 weeks, you can try to vaginal delivery if it's a contraction. If it's expectant, then it has to be no contraction, no bleeding, no fetal distress, right? So the placenta eruption, in summary, a painful trimester vaginal bleeding with rigid and firm uterus, no vaginal exam, clinical diagnosis, C-section if unstable. If it's stable, 34 to 36 weeks, you can try vaginal delivery if there is active contraction. Risk factor, hypertension, any type of preeclampsia, eclampsia, so hypertension, trauma, previous eruption, smoking, cocaine, and PPR.